Hi, folks. Welcome to the next video for CST 525. This will be on assessment and management of aphasia, chapter 5 in the J&J. So first, the roles of the speech language pathologist. So we can operate as a communication partner, a diagnostician, a therapist, a researcher, or an educator or an advocate for the patient, or an educator for the family, the caregivers. And we will operate oftentimes as both a clinician and a researcher. There's not really any division between the two roles. So because we're constantly evaluating the effectiveness of intervention, so in a way we are collecting data, we are tracking progress. We might not be publishing the data in peer-reviewed journals, or we might. But the function of us as operating from the perspective of a clinician and a researcher, they're kind of intertwined and related. And of course, we will be identifying both the intact language abilities and the cognitive linguistic impairments. So we're looking at both the weaknesses and the strengths. We want to capitalize on the strengths and try to increase the function of the weak areas. So aphasia, broadly defined, is a loss or impairment of language caused by brain injury. So this can be caused by a number of neuropathologies, including stroke. This may or may not be accompanied by comorbid alexia, agraphia, or agnosia. So alexia is the inability to read or understand words. Agraphia is the inability to communicate through writing. And agnosia is the inability to interpret sensation. So this is auditory information, visual information, tactile information. And hence, there's a deficit in recognition of things. And with respect to language, deficits may be verbal, expressive, auditory comprehension, reading, writing, and or nonverbal forms. So relative to assessment, all aphasia subtypes have this characteristic symptom of impaired naming or anomia. We can break them into subtypes, and they are differentiated by fluency, auditory comprehension, and repetition ability. One can also use standardized tests, such as the Boston Diagnostic Aphasia Examination, the Western Aphasia Battery Revised, and the Boston Naming Test to analyze the deficits in a systematic, structured manner. When one is looking at aphasia, we will describe the aphasia type, the severity, possibly the neuropathology, maybe the particular areas of damage to the brain, and we will look at adaptation to the pathology. What are they doing as a result of the deficits? What is their response to the deficits? And all of these factors will vary across individuals. We might want to look at a detailed language feature analysis. This would be kind of a part of an informal assessment. And you can look at the types of errors via error analysis, or you could potentially use a more standardized, structured assessment like the psycholinguistic assessments of language processing and aphasia. So here is an algorithm showing the different subtypes of aphasia. So you have a stroke patient here. If there's no naming problems, then that's not aphasia. If there are naming problems, we say that's aphasia. And so there are two basic divisions, the non-fluent and the fluent type. So non-fluent, that's that halting, broken speech, agrammatic speech. There's problems with speech output, typically in the non-fluent types of aphasia. With fluent aphasia, it's the more flowing, running speech. There's not the stop-starts, the halting pattern, but oftentimes, typically you get more auditory comprehension deficits in fluent aphasia and less auditory comprehension deficits in non-fluent aphasia, but there are better and worse auditory comprehension subtypes within non-fluent aphasia and within fluent aphasia. So if we're looking at specifically non-fluent aphasias, we've got global, Broca's, transcortical motor, and mixed transcortical. If you have poor auditory comprehension, that would be global or mixed transcortical. If you have good auditory comprehension, that would be Broca's or transcortical motor. Now, one can evolve from a global to a Broca's or from a mixed transcortical to a transcortical motor, given an improvement in the auditory comprehension modality and in the area of auditory comprehension. And the same thing can happen here. So with the fluent aphasias, we've got Wernicke's, transcortical sensory, conduction, anomic, and subcortical. So if you have poor auditory comprehension, that's typically either Wernicke's or transcortical sensory. If there's good or relatively preserved auditory comprehension, that's conduction, anomic, or subcortical. And just like with these over here, auditory comprehension can improve and aphasia can evolve from one subtype to another. So there's definitely a gray area between aphasia subtypes depending on the progression of the disease. And then once you get past the auditory comprehension branch here, you can look at repetition. If repetition is relatively preserved in the category of non-fluent aphasias, then you could say that's probably mixed transcortical. If there's poor repetition, it's probably a global non-fluent aphasia. If there is good auditory comprehension and good repetition, that would be transcortical motor. Good auditory comprehension, poor repetition, Broca's. And then you can see here. So poor auditory comprehension, but good repetition, transcortical sensory. Poor auditory comprehension and poor repetition, Wernicke's aphasia. Good auditory comprehension, good repetition, anomic or subcortical. Good auditory comprehension, but poor repetition, probably conduction aphasia. So these are the various subtypes of aphasia. You kind of broken down by fluent versus non-fluent, by auditory comprehension, and by repetition. So as I mentioned, fluent aphasia oftentimes comes with comorbid auditory comprehension deficits, although there are better and worse flavors of that. There are fluent aphasias with better auditory comprehension and fluent aphasias with worse auditory comprehension. So what is meant by that? That's usually defined as an impaired understanding of single words and or sentences. And as I mentioned, in good auditory comprehension subtypes, there still can be some reduced comprehension for low frequency words, abstract words, complex sentences. So the more difficult tasks, comprehension of low frequency, kind of rare words, abstract words, complex sentences, that's a higher cognitively, it's a task that requires a higher cognitive complexity. So therefore you would expect them to be comprehension of those types of words and sentences to be somewhat impacted despite the relatively preserved nature of these particular types of aphasia. So auditory comprehension for words. We can discriminate this relative to the type and severity. So obviously with less severe aphasias, there actually might be a confusion with and a confusion of interpretation with the patient being interpreted as being uncooperative, when in fact it is a less severe aphasia. So they might have some auditory comprehension deficits causing a poor command following ability, but it's actually due to the aphasia and not due to just being uncooperative. Education of family members and healthcare workers oftentimes is the purview of the speech language pathologist. Might have to educate regarding the type of aphasia and optimal communication methods. And relative to assessment of auditory comprehension, there can be a recognition without comprehension. So they kind of recognize objects, but they don't actually comprehend them, or recognize words, but they don't comprehend the words. So there are things that can be done, like for example, the assessment, the Birmingham Object Recognition Battery, which is a more standardized assessment, or you can do more of an informal assessment with lexical decision tasks, like presenting real versus not real words. And then the patient with aphasia decides whether or not the stimulus is real or not. So impaired auditory comprehension with respect to words often, well, it can involve impaired semantic memory. So that means that there's a poor activation of semantic features that differentiate single word concepts. So it's impaired semantic memory. There can also be a impairment of semantic categories. So you might assess this via kind of a category sorting task. You have a particular category, and the patient sorts items into the various categories. This could be a picture, kind of a sorting task. You might have divergent and convergent naming tasks, for example, also. So divergent might be name as many animals as you can in 60 seconds. So you have a particular category and you're listing off a bunch of items that fit that category. That's divergent naming. Versus convergent naming, you might give a description of a particular item, and then the person tries to determine what that item is. So for example, so for convergent naming, um, Golden Arches, hamburger, clown, Ronald, McDonald's. So that might be a convergent naming test. You're given a bunch of clues and you try to determine what the item is. And then there's a variety of matching tasks too that can be either upscaled or downscaled in terms of the difficulty by increasing the field size or the array size, by modulating the semantic relatedness of the item to the other surrounding items. So the types of foils or the types of distractors, you might say. So if you have a bunch of, say, a larger field would be perceived as being more difficult. And if items within the particular field are more related, that also might be perceived as being more difficult. So it's easier to discriminate a car from a horse versus a car from a truck, for example. And you also have to consider what modality you're testing always. So are you looking at the auditory modality, written language, pictures, objects? What are you actually testing? So relative to auditory comprehension of sentences, when we have sentences, now we're dealing with syntax, we're dealing with morphology, right? We're dealing with, in addition to semantics. So now we have a bunch of words in a particular sequence. So the verb and the particular verb forms, the order matters more now. So it will be easier for the patient with auditory comprehension deficits to perceive or to comprehend rather the sentence, the girl is pushing the boy, just a simple subject verb object sentence versus something more complex like a passive voice sentence. So the boy was pushed by the girl, or an object cleft. It was the boy that the girl pushed. One might have the patient complete sentence picture matching tasks. So you present a stimulus, the dog is chasing the girl. And so this could either be a picture or a sentence or both. And then you have a field that includes both the stimulus and some kind of a distractor. So you might have the dog, a picture of a dog chasing a girl paired with the dog is chasing the car. And so the patient has to choose the one that you say, for example, the dog is chasing the girl. And so they select the appropriate stimulus and disregard the distractor. You could also test differentially parts of speech. So you could test for nouns, so chasing, dog versus car. You could test for verbs, so chasing versus licking. Thematic role assignment, so object versus subject. So the girl is chasing the dog versus the dog is chasing the girl. So other cognitive deficits in auditory comprehension. So these refer to attention, working memory, executive function, so these other cognitive domains. So these are also needed for comprehension in functional communication scenarios, right? When you're dealing with multiple conversation partners, environmental distractions, attention is a big factor in having to deal with multiple conversation partners, maybe a divided attention or a situation of environmental distractors. You might have to tune out the environmental, the different elements of the environment. So you'd have to sustain focused attention and kind of ignore the irrelevant stimuli. In assessment, you might want to observe the person with aphasia in a variety of different communication contexts and look for patterns regarding how their overall cognitive status affects functional communication. Like, are there memory deficits impacting how they're able to convey themselves in a conversation? Perhaps they have a hard time keeping track of what was said or the flow of the conversation due to memory impairments, for example. Anyway, all of these things can be assessed via various tasks. So attention tasks, memory tasks, executive function tasks. So with respect to attention, you could modulate the environmental distractors, see how they're able to sustain focused attention, for example, given an auditory distractor, or you could see how they do a single task versus multiple tasks, maybe having a conversation while playing cards, for example, or maybe grouping cards by both color and by number, kind of going back and forth, or a trail task like we discussed previously. Memory. You might look at digit span. So how many digits they are able to remember in their working memory, and this could be presented verbally. They could use you could use pointing. Um, there could be a sentence to picture matching type of a task where you modulate the sentence length via modifiers. So instead of the large dog is chasing the girl, or sorry, the dog is chasing the girl, you might say the large dog is playfully chasing the tall girl. So sentence length can be controlled in that manner. And one would expect that the shorter sentence would be easier to comprehend. And you could also modulate the length and syntactic complexity of the sentence. So that would be kind of modulating sentence length, but then complexity, you could look at the simple subject verb object type of a sentence versus a more passive voice sentence. And then with executive function, you could kind of look at their ability to comprehend abstract versus concrete concepts. You could look at sequencing, and you could modulate difficulty by adding an increasing number of steps. All right, now right hemisphere damage. So when the right hemisphere is damaged, there are often concomitant comprehension deficits that occur. So this could be things like central themes of discourse. So basically the point of the conversation might be lost on these individuals. Connotative word meanings, figurative language, inferences, humor, emotional and linguistic prosody. So some of the more abstract aspects of language might be lost on the individual given right hemisphere damage. So with non-fluent aphasias, you have a reduction oftentimes in the phrase length, the quantity of output, speech rate, articulatory agility, grammatical complexity, thematic elaboration, and obviously there's this starting quality to the speech. It's a very different type of disfluency from what you see in stuttered speech. However, it is similar in the sense that there is a reduced articulation rate, and there's a starting and stopping pattern to it. Assessment of verbal and written naming. So there might be a deficit with respect to the spontaneous verbal or written expression of the individual. This task requires activation of semantic memory and abstract whole word lexical forms for spoken or written language. Oral reading and spelling requires a conversion from the grapheme to the phoneme in the case of reading, or from the phoneme to the grapheme in the case of spelling or writing. So, of course, the grapheme is the written symbol, and the phoneme is the speech sound, right? So there's a conversion aspect here. Additional modes of expression, such as gesturing, drawing, facial expressions, these can be preserved modes of expression for people with aphasia. And they may actually be able to use them as self-prompting mechanisms or even as primary communication modes, kind of a compensatory strategy. So lexical information is presumably held in your working memory during a motor programming task when you're expressing speech, for example. So lexical information is presumably held in your working memory during motor programming for expressive speech. So thus, if there were semantic or working memory deficits, then you would expect the expressive speech to be impacted. Breakdown can occur anywhere in the process, though. So it can occur at the level of the phonological output lexicon. There can be a disruption there. So you might have phonological errors for rhyming discrimination, for example. Do these words rhyme or not? They might not be able to do that kind of a task. You might have a graphemic output lexicon disruption. So the person spells words maybe cow instead of horse. So maybe they're semantically related, or maybe they're orthographically related, maybe weather for wheat. So they have a lot of the letters, the graphemes are similar. Or maybe there's a working memory disruption. So it could be phonological or graphemic errors of position, maybe. It might be initial, medial, or last position within the word. All right, sentence production. So here you have syntactic and morphological deficits in addition to semantic deficits. So with impairments of sentence production, you can have issues with simplifying the structure of the sentences. So potentially the patient would only be able to produce more simplistic forms. So subject verb object forms, they might have difficulty with passive forms. So that they could have deficits of either reception or expression, of course. And then there's morphologic deficits that can happen. So there might be impairment of verb inflections. One assessment that is good for assessing the morphologic deficits is the Northwestern Assessment of Verbs and Sentences. There could be an issue with active versus passive form. So you might ask, to assess this, you might ask the person with aphasia to produce an active sentence beginning with a given phrase. So start with the dog, that is, start with the subject of the sentence, using a picture stimulus. For example, a picture of a girl or of a dog chasing a girl. And then the target response is, the dog is chasing the girl. Then you ask the person with aphasia to produce a passive sentence beginning with the object. So start with the girl. So the target response there would be, the girl was chased by the dog. So see if they're able to produce both passive and then active sentences. You can also assess sentence production via a discourse type of an assessment. So this might be a story retelling using a quantitative production analysis method. So for example, you could use the story Cinderella. So you might review pictures from a storybook, close the book, and then ask the person with aphasia to retell the story. So functional communication and dynamic assessment. So there are a few tools for assessing functional communication, such as the Communication Abilities in Daily Living, the Communication Effectiveness Index, and there's a number of other ones, and you can kind of check the book for those resources. It's always good to work collaboratively with the person with aphasia to assess baseline life participation and set communication goals. Like anytime you're working with a person, you want to know what their goals are and what they were able to do before. What was their prior level of function? What do they want to be able to do? You can use dynamic assessment for these ends. So what types of modes of communication are intact? Which ones are impaired? Which modes do they prefer? What communication strategies work the best? What types and amounts of modeling or prompting yield the best results? Basically, we're trying to see how we can have the patient reach their full communicative potential. As I mentioned previously, you can focus on improving weaknesses, or you can focus on capitalizing on strengths. So if trying to improve weaknesses is kind of more of a restorative type of a focus. Trying to capitalize on strengths might be more of a compensatory type of a focus. So you could really go either way, or you could do both simultaneously. You could try to do both, improve weaknesses and capitalize on strengths. That would be a very kind of a practical way of doing it. The eventual goal will be generalization of some kind of a targeted skill, some kind of a gain that we make in therapy to some kind of a functional, non-targeted communication context or target. So a non-targeted aspect. And so as the patient regains function via this neuroplasticity that happens, and as lost knowledge is restored via this experience-based behavioral intervention, we might have to modulate these goals, and we might have to modulate the amount of prompting that we give, of course, because maybe less help is needed. And we don't want them to just become reliant on us, right? We want them to be able to eventually become independent as possible. So just a few therapy variables to consider. So what procedures are you using? Like, what is the methodology that you're using? What's the type of therapy that you're using potentially? Is it exercise? Is it constraint-induced therapy? Is it melodic intonation therapy? Is it swallowing therapy? Whatever the type of therapy we're doing for that person, you want to know, well, what is the type of therapy? What is the duration? So how many minutes per session, and how long have they been on caseload? The frequency, how many times per week? If it's somebody that might require more intensive type of a schedule, then maybe you could have a higher frequency, so 5 times a week versus 3. You could look at the number of repetitions or the number of sets that you have them do, and this doesn't just apply to exercise. You could also look at the number of linguistic or cognitive stimuli that you have them do in a given session. You can look at sequencing of the therapy within a particular session. So task order, you could look at progression, like how fast you progress through different tasks, through different targets and different tasks, different levels of speech and language. You could look at the effect of compensatory communication behaviors on rehabilitation of target behaviors. You could look at the interaction of different modes of communication. Like, are they Are they kind of like what's preserved and what's weak? So are they able to use a self-cueing strategy? Like, for example, could the non-fluent aphasic, for example, write down what they're trying to say as a self-prompting strategy? Um, are they able to generalize? How does practice on one target affect similar but untrained targets? Is there any carryover or attention after practice or after therapy is completed? Like they might have to come back for booster therapy if it's an outpatient type of a setting. Is that necessary? And one note about intensity. Oftentimes intensity is kind of referred to as how much effort per rep there is, but it can also refer to the schedule of therapy as well. So just intensity can be used in a few different ways. Okay, continuum of care. For the stroke patient, we'll be looking at the stage of recovery. Is this early? Is this late? Did the stroke happen 3 weeks ago, 3 months ago, 3 years ago? What's the intervention setting? That's going to kind of change how therapy is conducted. Acute care settings, subacute, inpatient rehab, home health, the patient's home, outpatient rehab. Are you working as part of a multidisciplinary team with other rehab professionals like occupational therapy, physical therapy, um, other health specialists, neurologists, primary care physicians, nurses, psychologists, social workers? You can interact and you can share information, if so. And there will be a modification of therapy goals as the aphasia evolves. So in the case of Wernicke's aphasia that evolves to conduction aphasia, given improvements in the auditory comprehension area, there might actually be an increased frustration due to increased awareness of deficits, because that's one of the symptoms of non-fluent Wernicke's aphasia is anosognosia, this lack of awareness of deficits. But if their auditory comprehension and their awareness starts to become improved, then they might actually become more frustrated when they attempt to self-correct. And you might have also an aphasia where it remains the same type, but it just gets better within that same type. So you could have a person that evolves from a severe anomic aphasia to a more moderate anomic aphasia, for example. Rehabilitation of aphasia. So there are some good resources here. You can check out this ASHA website, the clinical portal. It has some really wonderful resources on aphasia and aphasia therapy. You can check out the ANCDS website here as well. They've got some really wonderful evidence tables, although they are, there is nothing that is after 2016. So everything's a little bit older, but still a good resource. As I mentioned before, you want to capitalize on the strengths and address the weaknesses. You can potentially focus on one or the other or do both. You can have a restorative type of a focus where the goal is to improve or restore lost or impaired function. Or you could have more of a compensatory focus where the goal is to compensate for deficits non-amenable to retraining. So this might be, for example, in the cognitive area, you might have a patient with dementia, for example, and you're using external memory aids instead of just trying to give them loads of intensive memory exercises to try to impair the loss function. You're just setting up the environment in such a way that it facilitates better memory. So that would be a compensatory strategy. You can teach new skills to the person with aphasia and caregivers, of course. So things such as incorporating AAC if it's appropriate. And here's a short list of some selected treatment approaches. And you may actually look at this aphasia website and kind of look at some of these in more detail. These are included there, but there are also a number of other ones as well that are very interesting treatments, methodologies that you can dig into a little bit. So rehab of impaired comprehension. So just some general guidelines. You're going to want to start with a person with aphasia who has impaired comprehension. You're going to want to start with single words, shorter phrases, simple grammatical structures, high frequency words, concrete words versus abstract words. Slow the speech rate, over articulate, and you want to have moderate loudness. So not too soft, not too loud, right? Sufficiently loud. You will always want to be aware of hearing loss. So the hearing aid should be in. You want to sit on the patient's best side. If one side is better than the other, maybe one ear has better hearing than the other one. You're going to reduce the distance between yourself and the patient. You might want to even speak into their, not like directly into their ear, but close to their ear, kind of cheat towards their ear so they can see your face, but you're also speaking into their ear. You might consider pairing auditory and visual modes. So things like writing on whiteboards, potentially keywords. You don't have to write the whole thing necessarily, but keywords you might write down largely, clearly, with high contrast, like black or red ink on a white whiteboard. You might even utilize familiar objects in the room for pointing and identification tasks. So you're also going to want to identify safety hazards. So problems with ambulation, problems with transfer, and use of assistive devices. So falls are a significant issue in a number of different settings. I work in skilled nursing, and falls happen with relative frequency, and they are something that everyone tries to avoid. Diet, obviously, if they have maybe diabetes restrictions, and or they have dysphagia related diet restrictions, so that should be identified, obviously. If there's any medical directives from the primary care physician, such as non-weight bearing, or we had a patient in our skilled nursing facility that was given the directive: no BLT, no bending, no lifting, no twisting. So it wasn't bacon, lettuce, and tomato. It was no bending, no lifting, no twisting. Status post or after a lumbar 2 fracture, a spinal vertebral fracture. And you might want to look at use of supplementary oxygen. Is it PRN? Is it 24/7? All of these kind of things should be thought of in terms of establishing a high level of safety for the patient. Then you might also consider if the patient might have some sort of conceptual apraxia. For example, there was a patient that used sharp objects to brush their teeth. That's not something that's particularly safe. So then trying to limit access to sharp objects might be one particular consideration as well. To target semantic memory, you might use matching and sorting tasks where you can modulate the array size or the field size, the distractor type, how related or unrelated the items are to each other. Given a severe deficit, you might use a matching of identical items with one unrelated distractor. So an array or a field of 3 with 2 items that are exactly the same. So that might be kind of a good starting point. If the patient can't complete that simple task, then you might think that they might not necessarily be a candidate for therapy yet until their status improves. So general skills, you might look at auditory comprehension, so following multi-step directions, and you can make it more or less difficult by modulating the number of steps. You might use multimodal communication, or you might use AAC. So you're using whatever you can to yield the best communication. So this is more of the compensatory focus. So is the goal to challenge the patient within their zone of proximal development, right? You don't want it to be too hard or too easy. That would be like a restorative focus. So, or do you want to make communication as easy as possible? That might be an adaptation focus or a compensation focus. So you want to target the modality that's weakest if the goal is restoration. And you want to use multimodal means, AAC, use whatever you can, whatever is strongest if the goal is adaptation or compensation. So looking at deficits of gesture comprehension of gestures, there is actually a type of therapy known as visual action therapy, or VAT. So this is a nonverbal communication program, and it starts with simple tracing tasks. And it progresses systematically to gesture comprehension and production. So one task might be a gesture matching task. So the clinician might perform a gesture for a drink and present the client or the patient with a cup and a pencil object to match the gesture with the corresponding object. And there can also be the opposite could be done as well, where the patient is given an object and then asked to produce a gesture that fits that object. So rehab of comprehension with respect to single words, you could do cross-modality matching tasks. So spoken word to picture matching, where the clinician says, for example, the word apple, and then presents a picture of an apple and an unrelated distractor, and then the patient then picks the target picture. There could be written word to picture matching or spoken word to written word matching. So you can use whatever modalities that you want to in terms of what your target is. You can also modulate difficulty, as I've mentioned before, by increasing the array or the field size, and by keeping the distractors unrelated? Well, you increase the field size to increase difficulty, and you make the distractors more related to the target in order to increase difficulty. So first, what you might do is increase the array size and then keep the distractors unrelated. So you have a bigger field, but the distractors are unrelated. So in the case of apple, car, and blanket. Then you might change the semantic relatedness of the distractors. So they're more related. That means it's more difficult. So apple, grapes, banana. And then as performance improves, you can increase the array size and make the distractors more and more related to the target item to increase demands on the person with aphasia to make semantic distinctions. Another type of therapy that could be used for improving comprehension of single words is semantic feature analysis. This is a type of therapy in which the person with aphasia generates the semantic features of a given concept. For example, TV remote. It's a thing that changes the channel. TV turns on and off, runs on batteries. It's an electronic device. It's black, it's plastic and rubber. It's small. It's located on the table. So you kind of generate all the semantic features of a given item. So this has been used for naming deficits, but it has also been used for improving comprehension as well in the literature. And it works when both the patient generates the features and when the clinician generates the semantic features. So both strategies have yield improvements. Another type of therapy that's been used for improved comprehension of single words is constraint-induced language therapy. So this comes from the physical therapy realm, where patients with hemiparesis were forced to use the weak arm, the paretic arm, and the strong arm was constrained. So the strong arm here would be the patient's left arm, and they would be forced to use the weak arm in order to increase the strength of the weak arm. So constraint-induced language therapy is similar in the sense that the patient has to produce verbal language and speech. The patient is not allowed to use alternative nonverbal communication modes. So this is much more of a restorative focus than a compensatory focus. Evidence suggests that improvements in areas of comprehension occur as well as verbal production on a token test. So this is a viable method for improving both comprehension and production. With respect to rehab of comprehension of sentences, now we're targeting semantics, syntax, and morphology. So you might do a task such as a sentence picture matching task. There is one method known as a treatment of underlying forms of syntax, which involves improved sentence production and comprehension and generalization to linguistically related sentences. There is mapping therapy, which involves improved sentence production and comprehension, although the evidence in the literature suggests limited generalization resulted. There is the Helm-Esterbrook's language program for syntax stimulation, which resulted in improved sentence production and comprehension, although again, generalization was limited. And one could use sequential pictures to look at morphological deficits. So for example, future, present, and past tense morphology could be assessed or treated using sequential pictures. And the patient then tries to create a chronological timeline using the picture sequences. So this could result in this has resulted in improved sentence production and comprehension. There was generalization to untrained verbs that was found, but not to untrained sentence structures. So rehab of impaired expression. So there is a certain amount of overlap of treatment when you're looking at comprehension and production. So all aphasias include verbal anomia deficits, often with reduced or absent expression, and which is often present in alternative output modalities as well. So usually if the person has reduced verbal expression, they might also have concomitant writing, gesturing, or drawing expressive deficits as well. So a high priority for a person with aphasia with impaired expression might be establishing a consistent yes-no response. So just so they can simply communicate. You can craft a lot of communication. You can get a lot of stuff done just with yes-no responses. And so this is a very high priority. Like I mentioned before, you could use a restitutive or a restorative versus a substitutive or adaptation or a compensation approach. There is some evidence that constraint-induced language therapy facilitates verbal production and comprehension in persons with aphasia, as I mentioned before. Although this kilt type therapy typically involves very intensive treatment schedules. So whether or not that's viable or feasible might be dependent on, for example, what is allowed by the insurance in terms of the schedule. The impact of the therapy schedule is going to be a major factor here, and interactions with recovery timeline also is another major factor. You might look at multimodal treatment via the Promoting Aphasics Communicative Effectiveness program. This kind of provides the person with aphasia with alternatives when verbal naming fails. And so this might be well, when all else fails, try this, kind of a compensation adaptation kind of approach, a substitute approach. So with PACE, the SLP and the patient participate equally in dialogue, taking turns using their free choice of expressive communication modes to communicate new information. And the speech therapist provides feedback during the dialogue. And there is evidence that PACE improves verbal skills. You can also use direct practice of verbal naming, giving semantic or phonological prompting. So you could actually use semantic comprehension tasks combined with phonological output tasks. So for example, the SLP might say, which one is an animal? Presents a picture of a bear in a car. The patient then replies verbally, the bear. And then you could produce either semantic or phonological prompting if it's needed. If the patient has preserved repetition, you could capitalize on this by incorporating repetition in the therapy tasks. But if they have poor repetition, then you might want to go a different route, maybe training phonological awareness or semantic self-cueing or self-prompting strategies. Semantic feature analysis is an option. And as I mentioned before, both patient and clinician-generated semantic features have been shown to have positive results. You could also look at melodic intonation therapy for individuals with non-fluent aphasia. So melodic intonation therapy is a very interesting type of therapy. This capitalizes on the relatively preserved right hemisphere structures that are associated with musical elements. So assuming that the patient had left hemisphere stroke, for example, but the right hemisphere is relatively preserved, you could use this. So you might intone or sing short phrases, often paired with left-handed tapping of rhythms, then gradually increase to longer utterances and then fading the clinician prompting. How are you today? 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 So you can fade the different elements gradually to become more and more like actual natural speech. Treating gesture production deficits. So this will obviously vary with the source of the impairment. So if there's hemiparesis, the patient will be limited in terms of which limb they might be able to use, for example. And this might require some systematic practice. There are different modalities for this. So for example, there's the American codes based on Native American hand talk. And there's also American Sign Language. Just depends on how much, what the patient's goals are. Gesture production deficits might also be present given a semantic memory impairment, or deficits could be due to limb apraxia, and these can co-occur. So in visual action therapy, you can address the deficits in conceptual or ideomotor limb apraxia. So they might have the patient match viewed gestures to objects, kind of like what I mentioned before, where you gesture for drink and then present the patient with a cup and then a pencil, and then they try to determine which is the related object, for example. So you're kind of training both the conceptual and the motoric aspects of it. And there could also be a limb apraxia that's present as well, and that might be improved with repetitive gesture production and systematic feedback. So treating spelling and writing deficits. Writing deficits involve motor production of letters. So this can be impacted, of course, by motoric weakness or motor programming deficits for writing. So the patient might have intact linguistic spelling abilities using an alternative modality. So they might have preserved oral spelling or typing or anagram letter spelling. They might require assistance in letter formulation. So one high priority goal might, for example, be signing their name. So with respect to spelling and writing deficits, they can they can occur at the whole word lexical semantic level, at the sublexical phoneme to grapheme level, working memory level, allographic conversion of graphemic knowledge across font and case, visual processing level, motoric level. They can occur at any of these levels. So it's important to try to figure out exactly what level the deficits are actually occurring at, and then try to provide the appropriate prompting in order to just help improve the function, or to tax the system that needs to be taxed in order to improve it, given a type of restorative focus. So you want to localize the deficit area, target that weak area, or you could look at multimodal global functional approach. So spelling and writing deficits can co-occur with reading deficits. And so to kind of determine if it's written or oral spelling, it's a written or oral spelling deficit, you might assess multiple modalities. So you have them do written naming tasks, maybe verbal dictated spelling tasks, spell the word blank. So you might have them orally spell it, for example. What is the nature of the error? Is the error semantically or phonologically related to the target word? You might focus on semantic memory. You could focus on converting phonemes to graphemes, or vice versa. If you're looking at writing or reading, you might focus on whole word spelling practice, strengthening the graphemic output lexicon. You might, as I mentioned before, use writing as a self-cueing or prompting strategy if writing is relatively preserved in non-fluent aphasia. So reading deficits. Reading impairments can be differentiated by the error patterns, proficiency in reading regular words, irregular words, and nonsense words. In pure alexia, so pure reading issues without writing issues, there can be difficulty accessing the lexical word forms in visual word recognition. So in this case, a letter-by-letter strategy, reading strategy often works. So the patient would be able to read all stimulus types once they spell the stimulus aloud. So you might encourage letter reading to improve efficiency. Or you could discourage letter reading to focus on residual whole word recognition. You could even increase the speed of the presentation and response such that the patient's not able to do the letter reading. Or you could use multiple oral rereadings of a text passage. So with deep dyslexia, there are frequent semantic errors in oral reading. There's poor performance in reading nonsense words, and this is often due to problems with accessing the semantic memory from print. The semantic memory itself could be degraded, or they could have problems using semantic memory to access lexical phonology during oral reading. So any of these could be true. The problem could be in any of these areas, that is. So treatment here for deep dyslexia might focus on improving semantic memory. So the task might be pointing to picture corresponding to the written word. Might be a picture pointing task. So you're pointing to a picture corresponding to a written word, or it might be grapheme to phoneme conversion, with the task being oral reading of regularly spelled words. And as I mentioned before, there can also be cross-cueing strategies. So you might use a retained skill to self-cue to improve a weak skill. So for example, the patient might be unable to read from print, but might have a retained ability to pronounce words spelled aloud. So you might train the patient to name printed letters aloud to self-cue oral reading. Another example might be the patient is unable to read from print, but she has a retained ability to read by tracing the letters. So you might train the patient to trace the letters to self-cue. So technology and aphasia rehab, so AAC. So AAC is designed to replace, support, or supplement residual natural speech during communication. So this requires a careful assessment and individualized intervention. You should gear the AAC device precisely to the individual. One resource that's available is the ASHA SIG-12 website, which is provided here. There are 4 general aspects of communicative competence for individuals who rely on AAC. They need to have linguistic competence, so expressive, receptive knowledge of linguistic code of their AAC device, operational or technical competence to operate the AAC device, social competence, so social interaction skills, and strategic competence. So how do they deal with limitations due to restrictions of the AAC device? And the speech language pathologist should facilitate competence in each of these areas with both the person with aphasia and in their caregivers. You'll need to assess the individual's needs, their abilities, monitor their successes and failures, and provide feedback via some kind of a corrective mechanism. So high priority for use of AAC will be communication of basic wants, needs, and feelings. And AAC has a number of options. So there's low tech options, mid tech options, and high tech options. So you could have something that was more low tech, like single word communication cards, picture or photo dictionaries, communication boards, alphabet boards, eye gaze, drawing, and you can have various computerized devices, digital word image systems. You could have tablets or even dedicated devices. And in these, you're oftentimes able to customize a lot of different variables. So the grid size or the array size, you can make the images more realistic or more abstract. Is it a picture? Is it a line drawing? Is it in color or not? What's the font size? What's the color contrast? What's the access method? Is it a scanning method? Is it a direct selection method? What's the motoric selection method? Is it manual? Is it via a contraction of an eye muscle, for example, in a person with ALS? And what are the auditory output settings, for example? Other factors to consider with AAC, communication needs of the person, their life participation goals, their skill level. In some individuals, especially elderly individuals, acceptance of tech is kind of a difficult thing. They just might not be interested in anything that looks like a highfalutin, fancy technological device, Cost might be an option. Oftentimes these things aren't covered by insurance. Sometimes they may be, but oftentimes they aren't. The patient's motivation, of course. There is a tool that exists for assessing AAC. So the multimodal communication screening task for persons with aphasia assesses how a person with aphasia transmits messages using symbols and which prompting type helps the most. So this is a good tool for kind of assessing some aspects that might be useful for AAC. You could maximize residual communication strengths with this individualized approach. And of course, you're going to want to maximize residual communication strengths if you're using an AAC option. And as with other therapy, you're going to want to try to generalize from a more therapeutic context, highly structured, to less structured, more naturalistic contexts. And you may have to work on counseling with respect to acceptance of the AAC device, both by the patient and their families. Like one family member might have a preference. They want their family member with aphasia to be able to speak again, and that might not be viable. So there might be a certain amount of education that's involved. So research suggests that early and intensive cognitive linguistic rehabilitation is effective for improving communication in aphasia. But how much improvement should we expect? This is a tough question, and it relies on a number of different factors. Like, what is the severity of the stroke, for example? Like, what are the brain areas affected? Is it in Broca's area only? Is it multiple infarctions all over the brain? How long has it been since the stroke? If there's a little improvement that's been seen after 10 years, how much improvement can we really expect between years 10 and 11? If it's early in the process, though, you might expect there to be quite a lot of neuroplasticity and recovery to occur. Is conversation ability a primary objective, or do they just want to be able to express their wants and needs? There is a life participation approach to aphasia method. And this asks patients about their specific life aspirations, and it utilizes tools like life interests and values cards to tailor therapy towards life goals. So this is something that you might check out if you're interested in that kind of approach, and it's a really great approach, I think. Therapy needs to be functional and meaningful to the patient, and it tries to approximate spontaneous dynamics of real conversation. Aphasia groups can be wonderful. Here is a website, the National Aphasia Association website here that has some good information on group therapy. But in aphasia groups, patients can practice skills such as turn taking, topic improvisation. They can converse with unfamiliar communication partners. This facilitates self-awareness skills, a sense of autonomy, increases confidence, facilitates coping skills, and builds a sense of community within the individuals that participate in aphasia group therapy, and it reduces the sense of isolation. They might do, in addition to just general conversation, they might have role play tasks where you can generally increase the complexity or the task difficulty, things like discussing current events, simulating public speaking tasks, field trips to locations in order to converse with a variety of individuals. There can be book club conversations. All kinds of interesting tasks can be done in these types of aphasia groups. And then there are other social aphasia approaches, such as direct conversation therapy, conversational coaching, family or volunteer training, and self-advocacy training. So these target conversation and participation in other life activities and functional communication. All right, well, thank you so much for watching this video. I will see you next time.